we'll get us kicked off. So there's some great topics today, looking through the agenda, but I'll try to start you off with some thought-provoking stuff. We all struggle in deformity with PJK, but in the recent years, we started looking downward, and some of the failures that we've seen in the lumbopelvic region have actually been a little bit more abhorrent than we thought. In disclosure, ahead of giving the talk, I have been involved in a lot of this research, developed some of the products that have helped resolve some of these issues, including the granite screw that SI Bone has produced. But historically, the lumbopelvic and long fusions create a lot of force concentration at the lumbopelvic junction. And improving the fixation at the base tends to help disperse forces and reduce the failure mechanisms that we see with sacral fractures, pelvic fixation failure, L5 and S1 screw loosening, pseudoarthrosis, and rod fracture. But when we do these long fusions, there's a force transmission that occurs through the SI joint. Whether it's ankylosed or we fuse it, you see this FVA on what that means to the SI joint. So that's a force transmission that means increased motion, stress at the joint, degeneration, and perhaps clinical deterioration. There's been a lot of basic science and biomechanical research on this topic of recent years. When we look at that, when we look at how we fixate, you see here this study with significant reduction in lumbosacral motion and mean S1 screw bending moment inflection when we bind or don't bind the SI joint. And there's an increased rod strain. So the way that we manage the SI joint has some good and bad effects on the implants and instrumentation that we use to fixate the lumbopelvic junction. Other studies on an FEA basis have shown this increased stress at the SI joint, the more levels that we fuse. So deformity is a real hot topic in terms of our impact there. In general, the indications for starting to look at managing the SI joint proactively come down to pre-existing SI joint pain. So it's really, I think, incumbent on the deformity surgeon to look at that pathology ahead of doing a deformity operation through exam, verification through injection, and then considering binding the joint durably, fusing it so that it does not become a deterioration impact for the patient on a clinical basis. The rationale for some of this is based on many studies that have come before us looking at the clinical syndrome as well as the instrumentation failure rates. This study by Anna, I'm not going to say the name because I'll screw it up, but the presence of SI joint pain at baseline with deformity operations was associated with a higher mechanical complication, about 15%, and then reoperations rates of about 32%. Additionally, revision rates in these patients with SI joint pain are about 30% at 2 years. So significant and obviously a cost issue or health economic driver for making a good decision on the front end. The SI joint mechanics in a pathologic state also change. We're starting to look at this in the spinal pelvic study group. And when you do these deformity operations and the SI joint continues to move, it actually accelerates the amount of motion that it typically derives. A typical male SI joint may move at 1 or 2 degrees in rotation, or we call it nutation. When you do deformity operations and you create that increased stress, you can see it go up to 5 to 10 degrees. And because that's so foundational, if you swing that many degrees in what's essentially a rotation, it can affect your sagittal plane in a post-operative deterioration mechanism. So it can be partially responsible for an eventual deterioration in the sagittal plane after your original correction. So important to look at. The other thing that we're starting to realize is that the alignment that you achieve matters. If you have a persistent pelvic incidence lumbar lordosis mismatch based on this paper, you're more likely to have SI joint pain, and we're seeing that in some of the other deformity papers that we'll get into. This can happen early or late. This is sort of an interesting study looking at early incidence, and this is just 20 days after surgery, there was a 12% incidence of SI joint pain escalation. So early, perhaps early force transmission and pain provocation of the SI joint. If you look at it more broadly, in terms of a systematic review, and you parse out degeneration versus the actual clinical pain syndrome, there's a differential. Not all degeneration leads to pain, but you can see here on the left side, looking solely at degeneration, there's pretty high rates of degeneration, which vary at a higher rate than the clinical syndrome. Over here, a number of studies, more or less quality. Probably Inoki's the best quality, and we'll go over it in a bit. But there's this blend of studies that look at SI joint pain in the long term after deformity operations or lumbar fusions, and you can see a reasonably high blended rate, probably 15 to 20%, if you compare and compile those studies. Some of the better studies in that group, Finger study looked at worsening or new onset SI joint pain after lumbar fusions, about 32%. And it didn't seem to matter whether they had sacral fixation alone or pelvic fixation. So this is really about the extent of the fusion and the stiffening of the lumbar spine, regardless of pelvic fixation. And this was at a pretty high severity rate, 6 on the VRS. Again, 7 published papers on that same thing. I'm going to go into Inoki's paper because his was unique in that they did a confirmation of no SI joint pain before these constructs were performed, and then looked at the number of levels and the rising incidence in SI joint pain. And you can see the escalation in prevalence as you get to higher levels or greater levels of fusion. The other question that came about with some of this work was, did it matter what kind of fixation you used in the pelvis, if you used it at all? And so if you look at this, this work, you can see that there's a little bit of a variance, but it doesn't seem to matter, again, whether you just stop at the sacrum or use iliac or S2AI fixation. They all have some contribution to SI joint pain. Going back to this concept of perhaps some escalation in pelvic incidence or change in pelvic incidence, which we didn't think could happen, but it seems as though it may be able to happen based on some of our recent work. And when you have this change of PI of more than 4 degrees, you get this escalation in SI joint pain. That may be a chicken and egg thing. As you get more motion, that may underlie that there's more stress in the joint and therefore more pain provocation. Peter Passius did some recent work looking at a large cohort of adult spinal deformity patients that were going sagittal plane deformity correction. And about 30% of them had baseline SI joint pain based on exam. These weren't verified by injection, but just exam. And they tended to have greater deformity, those that had SI joint pain. And about a third of the patients that were verified on exam to have SI joint pain underwent SI joint fusion concurrently with their deformity operation. But only about 65% of those with SI joint pain pre-op had resolution by 2 years. So that tells you somewhere around 10 to 12% of patients had persistent SI joint pain of significance. And that was associated with a less ideal alignment achievement. And then looking more specifically at that, matching the gap lordosis distribution index tended to increase SI joint pain resolution. So getting alignment right is meaningful. It's not completely going to resolve the dilemma and eliminate the potential, but it's definitely something to shoot for. Recently in the ISSG, we looked at baseline and post-op SI joint pain in a little bit of a rudimentary way. It was somewhat retrospective, and it wasn't verified with injection. But basically, I'll say without full clarity on the veracity of the exam, which is difficult and not necessarily well known by all surgeons, about 7 to 8% had baseline SI joint pain in the deformity population being treated. It was associated with higher BMI, lower lordosis in the lumbosacral junction, and greater L1PA values. And then post-op, that rate didn't change. There were about 8.3% had confirmed SI joint pain at 1 year, based on exam again. But very interestingly, about a quarter of the patients had moderate to severe pain in an area that would be considered potentially from SI joint, but not confirmed by exam. So it leaves us with a little bit of misunderstanding about why there's a differential there. You don't want a quarter of your patients to have moderate or severe pain, but nonetheless, that's where we're at. So without injections, we're not totally sure, but importantly, that rate leads to a clinical deterioration or less ideal patient-reported outcome status. A lot of this understanding of the clinical pain syndrome and then the radiographic failure rates led to further study on what we could do to intervene on that basis. This bedrock study that we did was cadaveric, and it was looking at whether adding additional fixation across the SI joint in addition to pelvic fixation, so 2 points essentially, not necessarily to the construct, but just 2 points to bind the SI joint, would change the mechanics. And in fact, it did. When you add those 2 points on either side, you get a significant change in the range of motion of the SI joint. So it's clearly helping avoid escalation and stress and range of motion of the joint. And it also reduces stress on the S2AI screw. Motion at the SI joint would theoretically create stress on that screw along with the rest of the construct, focusing or concentrating stress there. And it reduced bending moments on the screw as well. So perhaps a means of reducing some of the radiographic failures that I talked about earlier in our retrospective studies. An example of this kind of technique in the study was, as you see here, scoliosis correction, and then we used a triangular implant, in this case with a standard S2AI screw configuration. This Sylvia study that was engineered by SI Bone was a prospective study, so a little more rigorous in the capture of the patients. The preoperative examination and use of injections was also performed, really to identify clinically whether we were going to get radiographic and clinical benefit out of doing this sort of bedrock technique. And what we found was, similarly to our ISSG study, there was new onset SI joint pain in about 8 to 9% of the patients that underwent this. And importantly, we just used S2AI screws in the study just to keep things homogeneous. And when we used the triangular implant in the cohort that had that in this randomized trial, there was reduced SI joint pain in the follow-up, reduced S2AI, tulip failures, and lucency rates. So it seems to be managing some of the mechanical failures to some degree. You can see the numbers there. So considerations for SI joint management in the context of deformity operation. Certainly when you're doing adult deformity, you should be thinking about it as a coincident diagnosis, and then be thinking about it as well in the setting of pre-existing SI joint degeneration, patients that are at greater risk of developing issues, those with high pelvic incidence or BMIs tend to have greater risk of failing. Now there's lots of techniques to manage it. In the case of a de novo, when you're doing a deformity operation, it's a little hard and I would say miserable to have to do bilateral, lateral to medial, which we typically do for just a degenerative SI joint. So we're really looking at sort of a medial to lateral trajectory in that scenario just to be efficient and not have to create new incisions and create extra length of the surgery. But there's lots of ways to skin the cat. This is just a picture of all the different sort of SI joint interventions that are out there and different implants that can be used. Some of them interfere with or are complicated in the setting of a deformity operation. The implant on the left there is very effective, but it actually tends to interfere with S1 screws. You can't put pelvic fixation in very readily. If you're doing a deformity operation, then it's obviously a lateral to medial trajectory implant. And then other implants like this that are out there. So for a postoperative state where you develop SI joint pain, you might be able to use some of these things, but in the de novo, more challenging. If you haven't read this is a good compilation of what's out there on SI joint in terms of managing SI joint in a minimally invasive fashion and what the data really represents. And the summary is that it works for SI joint pain to stabilize and fuse. The ODI, the PROM outcomes are best currently relative to the data with the lateral to medial trajectory. in the degenerative state. In the deformity setting, as I said, it's more complicated. You have to be thoughtful about workflow, efficiency, and it's much more ideal to use a medial lateral trajectory. The downsides, you're non-orthogonal to the joint. If we're not perpendicular to the joint, for the neurosurgeons out there, it just tends to be less ideal mechanically. But if you have an integrative sort of implant that can get bone to attach and grow through it, it may still be effective. You do have direct access to the joint, so when you're doing open deformity, you can actually burr it out, lay graft in, and facilitate the fusion. More than 2 points or 2 or more points are likely necessary. The SI joint's rotational in its behavior, so if you have a single point, it can pivot on that single point, makes very clear mechanical sense. And we've seen that the integrative implants really do work well at maintaining fixation. It's just a biomechanical study looking at the ability to ingrow, ongrow bone onto the implant, what that means for its fixation, integrity, and durability, which you can see here is 3 times that of a standard screw. And so some of the solutions out there involve a screw that can withstand the cyclical strain and loading that occurs as a result of ongoing motion from the SI joint, as well as the lumbopelvic strain from a long lever arm with deformity, so that you have this durability of fixation and you don't have attrition through a standard sort of buttress screw that can fail over time. There's obviously different approaches to the grafting. In the primary setting, onlay and packing grafting with traditional fixation, and then 1 or 2 points of fixation per side. If you're trying to fixate and fuse, you're probably more ideal with 2 fixation points. And then bioactive implants are likely to be more durable and effective, but we're still collecting data on that need. Here's an example of sort of a stacked configuration from Dave Pauly on the bottom. Placement's tough. When you start putting 2 implants in the pelvis and you're trying to get length and girth, you can run out of real estate pretty quickly. We do know that your best biomechanical fixation's down low in the arteria, right over the sciatic notch. So that's sort of the home run screw. That's where you focus most of your attention, and then you fit the other implant above that best you can. This is an example of placing it fluoroscopically. That's what I've had to do for many years doing MIS. Now I tend to use NAV. It's much easier, and I don't feel like I'm radiating myself into oblivion at the end of the case. So it's nice to know how to do it, or even to check your work if you don't have a 3-dimensional spin technology in your operating room, or if your tech goes down. So you have the option to do it. But typically the nav and robotics, I think, are going to be where we go with this. In the Sylvia study, it definitely had a little bit of uptick in precision in getting implants in, so think about doing that for efficiency and safety. There are alternative implants for SI fusion and deformity settings now. The Sylvia study happened. That was sort of a standard screw at the S2AI position and a triangular implant. A little bit cumbersome to do that second part. This is an example of an MIS approach to using this concept with a physician who had a sagittal plane deformity, as you can see, and he had a 2-pronged approach with a single position, anterior and lateral recon, and then percutaneous fixation in the back, where we used an integrative screw at the S2AI site and then an integrative non-rod fixated screw at the S1AI position. So you're getting SI fixation in 2 points, but because of the ALIF, I didn't feel like I need 4 points of pelvic fixation. I'm happy with the biomechanical consideration.
That's a rod bend.
Huh?
That's a rod bend. That's impressive.
Yeah. Well, so we had to match up with his old fixation, which was done open. Yeah. And so I had to use some rod bending technology to meet those sites without stressing the screws and obviously get it over to the S2AIs. So stacked SI screws, SAI screws are probably going to become more utilized, maybe even bypassing the need for S1 screws. If you've got those fixation capabilities, you get the benefits of SI stabilization at 2 points. You get ample fixation caudal to this the L5S1 level. So we'll see. I think that you'll see that come into more vogue. And then, if you have staged SI joint pain and you have to deal with it, there's different ways to skin the cat. This is an example of a woman who sort of failed with a pseudo T-lift, never seen that happen. And still had some sagittal pain, pretty old, pretty frail, so I didn't want to overdo it on her. And so we did a revision approach to that T-lift and kicked her back a little bit more, and then used a sort of muscle sparing splitting approach on the sides and the back. But you'll notice I had to use a lateral to medial approach on the left side. She had confirmed SI joint pain going into this, but she had really proximate S1 screw and iliac screws on the right side here. So I couldn't fit an S1 AI or an additional pelvic fixation point like you see on the left side. So I just used a separate trajectory and sort of hybrided that approach. So in summary, with SI in general, and then SI and deformity, you can reduce the strain on rods, the S1 screws, and iliac fixation by managing the SI joint in a stabilizing fashion. Probably with 2 points, that's best. It's going to provide for improved durability of the pelvic fixation. It's going to reduce the risk of loosening iliac fixation failures on a long-term basis. It remains a little bit a question whether it's going to be meaningful in the clinical syndrome that we see over a longer period of time, but it looks promising that it will do that. And then, ultimately, we'll probably need a little more data to be doing this on a widespread basis, but certainly look for the clinical syndrome in any patient that's undergoing deformity operation. Thank you.
As always, I have a question. First of all, thank you for the superb, foundational, in the truest sense of the word, lecture and the clarity of your didactic delivery. Always find it personally very rewarding. My key question, if you can go back to the stacked screw slide, just a couple of things. Had the nice no, keep going back a little more. Yes, perfect.
Yeah.
So my question to you is the following. So right now what I'm witnessing is a arms race. I could call it a screw race of more and more hardware to kind of stabilize this recalcitrant, clearly critical joint, and trying to find some form of osseous integration. I call it metallosis with a little bit of cynicism in my undertone. Why not, and this case is so evocative for me, concentrate on a really high quality osseous fusion? You mentioned that several times, but why more hardware and bigger hardware that in case of failure is an absolute disaster to try to deal with, and I have several of those patients in my practice. This gap post is on that left side of this eye joint. Doesn't that just call for a big, nice, osseously active agent to be delivered into that joint to get that to heal, rather than more metal to try to get some trans-osseous maybe integration via hardware with bigger and bigger calibers?
Yeah, that's a complicated question, but let me try to tackle it. Number one, the move to the stacked fixation has really been on the heels of a limitation in posterior-only surgery, because the stress at the lumbosacral junction has met with greater failure with non-unions and failure in the lumbosacral junction with single side fixation, meaning single points of fixation bilaterally. So most of the data that we've seen at the ISSG and broadly, I think, has led to us using quad fixation, okay? The stacked screws, not because of the SI joint, but because of a need to increase the fusion rate, decrease the failure rate of the lumbosacral junction with posterior interbodies or no interbodies. ALIS are probably different. They offload the posterior fixation better. So the data is not clear that you need quad fixation or stacked fixation in that scenario. That's a different discussion than what are we doing with SI joint and what's the rationale. I don't think you're wrong. I don't know that we know the answer. If you're doing MIS, you're kind of stuck. You need an integrative type fixation. If you're in an open and you can graft the joint, then it's just a race against time. Is a single point of fixation enough if you really graft the crap out of it? Maybe, we don't know. Going through all those x-rays for the ISSG, there were some old school fusions where there was a mound of bone graft going from the ilium to the sacrum to the spine. So it looked like a giant Christmas tree of bone graft, and they tended to do pretty well, but that's a more morbid exposure, to be sure.
So if I may just add to this, and this is why I thought this was so evocative, and comparing that to the physician's image that you showed, in this era of personalized medicine, which every lame consultant sells to every major medical system around for vast sums, this is a great example for personalized medicine. This gap poses in there, in that SI joint, screams for implant failure, despite perfectly placed, really cool, nice implants and nice realignment. This is a osteocyte jumping or osteoblast jumping distance that might exceed anything that we can put in there. If you go forward now, if you don't mind, to that beautiful physician case a little bit further. You had a nice, for instance, this one, perfect. There's no osteocyte jumping distance in that SI joint. That may even be partially ankylosed due to an inherent inflammatory disease. So this is where I put a pitch out for highly sophisticated large database managers like yourself and very sophisticated deformity surgeons to apply more personalized medicine criteria for the osteoblast jumping distance of an SI joint and developing more sophisticated ways to actually measure SI joint instability.
Yeah, I agree.
Yeah, great thought.
Microphone, can you use the microphone? We have an online.
The length of the what?
The length of the S2AI screw, have you noticed? Initially, I used to put like 100 or 80.
So the mechanical data suggests a minimum of 80 is ideal. When you get less than 80, it's probably insufficient. And then girth-wise, you're talking about probably 8.5 or north of that, or you start seeing a lot more fractures. They see a lot of bending moment. So 8.5 or greater diameter, 80 millimeters or longer, tends to get to that point of probably diminishing return. Now, some people are putting 100s, 110 in. I don't know that that's meaningful. You probably have to vary that based on patient anatomy so that you're getting the sciatic notch bone, and then as you ride that, you're probably okay. But that's the other question, if you're blindly putting these in, you're doing sort of the old school, I'm just going to aim for the greater troch, and I don't know how close I am to that solid notch bone. It does change the mechanical behavior of the screw and its fortitude. So you might be able to go slightly shorter if you're in perfect position. You might need to go longer if you're in less ideal position. Answer your question?
Yeah, that did, because I initially was putting around 70 to 80, and I still had some post-op, pain on some of the patients. I was talking to some colleagues, and they were pushing 100.
Yeah.
And so now I started putting a lot of 100 millimeters, and I've noticed my post-op pain has gone down quite a bit.
Yeah. So key number is 80. Get 80 plus.
Yeah, I've noticed, typically the type of screw as well. You're using S2AI or modified iliac, because for me that makes a big difference. If you're really getting it low with the S2AI screw, typically in women I'll do an 80. If I do longer, sometimes I'll get a lateral breach, which is not the end of the world, but kind of being overly aggressive doesn't look great on your post-op scans.
Right.
So yeah, I definitely would recommend kind of altering it, but yeah, 80 minimum. Right. I think typically will always work. One question that I had, obviously, we're doing some patients poorly by, not fusing their joints in deformity surgery. But at the same time, it's a fairly small percentage that end up with that post-op pain. Any strategies that you have for trying to differentiate the person that needs that, open SI joint fusion that, if we're there doing a big T10 to pelvis, it's pretty straightforward to graft it, put an extra screw in.
The low-hanging fruit in my mind is do the exam when you're seeing them and indicating them for a deformity operation. If they have preoperative SI pain, why not? You're just begging for trouble. Now, what we don't know, and the missing link is the deformity itself can drive SI joint pain. So when you correct the deformity, it seems some people actually improve. The problem is we don't know who that's going to be. And then other people deteriorate as a result of the fusion or the deformity operation. That's a harder nut to crack. At some point, we're going to have to wrestle with the health economics, like we did with BNP once upon a time, where we said, okay, that's expensive. What's the number we have to get to economically to warrant doing it on everybody? I don't know where we're going to get with that. It'll depend on the cost of the implants and the extra juice that we throw at the problem. But once we define the clinical syndrome more precisely than we've done, then we can do the health economics. Okay, everybody's getting it, because if 10% of people end up deteriorating in their proms, and/or needing secondary surgeries, that's not okay. It probably is too much of a cost driver.
Well, great. Thank you.
Yeah, thank you guys.